This is lecture 25 on the female reproductive system. Finishing our two-part reproductive lecture series, we'll begin with the female reproductive system. The overall functions of the female reproductive system are very similar to that of the male reproductive system. It produces sex hormones, namely estrogen, progesterone. It produces functional gametes, known as the ova. It protects and supports the developing embryo. It maintains the growing fetus, and it nourishes newborn infants. Now, looking at an overview of the female reproductive system, the female gonads are called the ovaries. They produce gametes called oocytes that mature eventually into an ova. An oocyte is going to be an immature ova. They also produce hormones, namely estrogen and progesterone, which we'll get to a little bit more later. The female reproductive tract is designed to conduct the ova, the oocyte, and eventually the ova into the development area. So there's the uterine tubes that will actually collect the oocyte or embryo and deliver it to the uterus. Typically, the uterine tubes are where fertilization occurs of this oocyte. It will transport it to the uterus, which is the site of fetal development. So once the ova is impregnated by a sperm, this would be where it would actually physically develop, is inside the uterus. The vagina actually connects the uterus to the outside of the body, and this is the site of the sperm deposition. It is also the birth canal during delivery and a passageway for fluids during menstruation. The external genitalia of the female reproductive system includes the clitoris, the labia, and the mammary glands. The clitoris contains erectile tissue and becomes stimulated during sexual arousal. The labia are going to be the different lips that actually surround the entrance to the uterus or the vagina. These contain different glands that lubricate the entrance to the vagina during coitus. The mammary glands are going to produce milk to nourish the newborn infant, and they would actually be in the breast tissue. Here we can see a diagram overview of the female reproductive system, including the ovaries, uterine tubes, uterus, vagina, the external genitalia, and of course the mammary glands in the breasts. We're going to start our journey through the female reproductive system through the ovaries. Now, the ovaries are small paired organs that are at the upper angles of the broad ligament. This is going to form a triangle. They actually serve two main functions. First is the production of immature female gametes or oocytes, and then the secretion of female sex hormones, estrogens and progesterones. Now, there are several layers to the ovary. The first is the germinal epithelium, which is going to be a layer of squamous and cuboidal cells covering the ovary. Then we have the tunica albuginea, which is dense connective tissue just deep to this. So these are going to make up the layers of connective tissue. Once we get inside the ovary, we have our cortex and our medulla. The cortex is going to be where the oocytes are produced, and the medulla is simply the core where there are blood vessels. Here we can see a diagram of a cross-sectional view of the ovary and the uterine tube, as well as the different ligaments that connect them. So the ovary, as I've stated before, the outermost layer is that germinal epithelium, and just underneath that germinal epithelium is the tunica albuginea. This is going to be the connective tissue that wraps itself around the ovary, the ovarian cortex. Again, the cortex is where oocyte development will occur, and the oocytes will be in different phases of this development. The medulla is actually going to be where the blood vessels insert, and the blood vessels come in directly from the ligament. Now, there's a number of connective tissues and ligaments that stabilize the ovaries in place: the ovarian ligament, the mesovarium, and the suspensory ligament. We're going to discuss these in the diagram on the next slide. Here we can see the uterus laid out with the ovaries on either side and the uterine tubes extending out from the uterus. Note the different ligaments and their placement. We have, of course, the broad ligament, which is going to be a large ligament that stabilizes the uterus and oviducts as well. It's going to connect the ovary directly to the suspensory ligament and the mesovarium. The mesovarium is actually going to be a collection of blood vessels and ligamentous structures that attaches the uterine tube directly to the ovary and stabilizes it. Finally, we have the suspensory ligaments that provide lateral stability and house the ovarian artery, vein, and nerves. Additionally, the ovarian ligament itself connects the ovary directly to the uterus. The ovary is not connected to the uterus via the fimbriae or the uterine tube. It is connected via the ligament. So that means the ovary, in a sense, floats separate from the uterus and is simply attached via different ligaments. Now, the uterine tube extends out from the uterus and expands into a funnel-like infundibulum. This is actually where it's going to have finger-like projections called fimbriae that are going to direct the ova into the infundibulum and the uterine tube or fallopian tube. The other end of the uterine tube is going to attach itself to the uterus, and the uterus is going to be inferior to the ovaries and above the urinary bladder. Here we can see a cross-sectional diagram of the female reproductive system. Note the urinary bladder is anterior to the uterus. The uterus has the uterine tube that branches up and off of it, ending in the infundibulum and the finger-like projections known as the fimbriae. The fimbriae do not touch directly the ovary, even though in some diagrams it looks like it does. When the oocyte is released from the ovary, the fimbriae will grasp this oocyte and pull it up towards the actual uterine tube, which would then progress its way to the uterus. We can see behind the actual urinary bladder is the uterus, and then the urethra extends out from the urinary bladder, whereas the vagina is posterior to the urethra. We're now going to go through a series of slides that are going to talk about the origin of the oocyte and how eggs form in the female. We'll start, of course, with oogenesis and then move through the overall process of the ovarian cycle. Now, oogenesis is the formation and development of the oocyte. It begins before birth and accelerates at puberty and ends at menopause. Now, there's a lot of different events here that are the same as spermatogenesis, namely the meiosis phases, but they occur at different timings, and we'll get into that in a little bit greater depth. So first, the ovarian cycle involves changes in the ovarian follicles themselves. Here, specialized structures where oocyte growth and meiosis 1 will occur are going to have about 2 million primordial follicles that start. Each of these follicles contains a primary oocyte. Now, by puberty, there's only about 400,000 primordial follicles that remain. The others have degenerated over time. So you get 2 million, and then there's this process of atresia that happens that starts to break them down to where you have about 400,000 of these follicles that remain. Now, once puberty actually starts and a woman gets her menses, each month she will start to stimulate or release follicle stimulating hormone that stimulates the development of these follicles. Now, we're going to start before we ever get to puberty. This is going to be at the production of the primordial ovarian follicle, and this begins during gestation, so just at about 3 to 7 months old. A female stem cell, or oogonia, is going to, in the egg nest, is going to divide and create a primary oocyte. So it's got 2 there. And it's going to actually have a set of 2 chromosomes here. And then it will continue to divide and undergo meiosis 1, but it's going to stop in early sequence. So what this is going to be the same thing as spermatogenesis in that we're starting and initiating the process of meiosis, but freezing it. So meiosis begins during this stage, but then stops until it actually gets a hormonal response to continue later on. It's like prepping things beforehand. Here we can see a diagram with the primordial follicles in the actual egg nest where they are set, ready. They've begun meiosis 1, but they have frozen in place. Next, we begin the first step in the ovarian cycle, and this is the formation of the primary ovarian follicle. Here, an increase in follicle stimulating hormone, which comes from the pituitary gland, is going to signal several primordial follicles to develop into a primary follicle. During this process, the follicle cells surrounding the primary oocyte divide repeatedly. This increases the thickness of the follicle and creates a narrow space called the zona pellicula. Between the oocyte and the follicle, the cells are now called granulosa cells as they have granules throughout them. An additional layer of thecal cells are going to form outside the follicle, and the primary oocyte is going to form, but it's still diploid during this stage. Here we can see an example of it as it is grown and thickened. We can see the granulosa cells, the primary oocyte, and the thecal cells. Now, the thecal and granulosa cells are going to secrete estrogens. Estrogens have the following functions. They maintain the function of the reproductive glands and organs. They initiate repair and growth of the uterine lining. They maintain female secondary sex characteristics, namely softer skin, fat deposition, as well as hair growth. Stimulates bone and muscle growth, and it also stimulates sexual drive and behaviors. Our second step is the formation of the secondary ovarian follicle. During each cycle, many primordial follicles form primary follicles. However, there are only a few of these primary follicles that will move on to form a secondary follicle. During this stage, the walls of the follicle thicken and produce a follicular fluid which fills the pockets of that narrow space, the zona pellicula that we discussed. The follicle is going to grow much larger due to this fluid accumulation, and the oocyte remains diploid, although it does grow in diameter. Now, usually only one follicle completes the transition, and the secondary follicle degenerates. So here we can actually see the thecal cells, the zona pellicula, and the nucleus of the primary oocyte where it is thickened beyond. And there's not, the other one has already begun to degenerate during this time period. Now, the next step is the formation of the tertiary ovarian follicle. At 8 to 10 days after the start of the ovarian cycle, there is usually only one remaining secondary follicle. Over the next 2 to 4 days, it develops into what is called the tertiary follicle. The fluid pockets here have merged and formed a fluid-filled antrum, and the oocyte remains attached to one side via a ring of granulosa cells called the corona radiata. During this phase, the primary oocyte finishes the first phase of meiosis, becoming haploid and producing a non-functional polar body. Most of the cytoplasm in this stage and organelles will remain within the secondary oocyte. So here we can see the tertiary follicle. We have a membranous cover, the corona radiata, that will surround that secondary oocyte that has begun its development, and we have a very large antrum containing the follicular fluid. Now, the follicular fluid will become important later on after the ovulation stage, but during this stage, it's simply going to keep growing larger as the oocyte continues its development. We are now at what we would call the end of the follicular phase of all the events that occur inside the follicle of the ovary and transitioning to the luteal phase of the ovarian cycle. And this is with step 4, ovulation. So around day 14 of a 28-day cycle, a rapid increase in luteinizing hormone, estrogen, and a spike in the follicle stimulating hormone results in the expulsion of the ovum from the follicle. This is called ovulation. The ovum is surrounded by a shell of granulosa cells, the corona radiata, and it moves slowly across the mucus-coated surface of the ovary until it enters the fallopian tube. Ovulation also causes the fimbriae, which are attached to the infundibulum of the uterine tube, to swell and cover a portion of the ovary. The cilia on the fimbriae are going to help to direct the ovum to the fallopian tube. The ovum now moves along the fallopian tube down towards the uterus. Upon fertilization, the oocyte would then undergo a second asymmetric division, resulting in a large haploid ovum and another polar body. The DNA from the ovum and the spermatozoa would then combine to form a zygote. In this case, the secondary oocyte begins meiosis 2 but stops partway through, and it finishes when fertilized. Now, fertilization occurs, this will continue. If fertilization doesn't occur, then the oocyte simply degenerates and gets passed through menses. Here we can see ovulation. That antrum is going to then burst as the oocyte is going to push its way out and rupture the follicle. Here we can see an actual example of that egg as it's pushing its way out of the ovary and the follicle, and it gets its way towards the fimbriae. From here, we now enter into the luteal phase and start with the formation of the corpus luteum. Here, the remaining cells of the follicle form the corpus luteum. This creates and releases the hormone progesterone. Now, progesterone prepares the uterus for pregnancy. That's its primary function, is to increase the maturation of the uterine lining for pregnancy. Now, if fertilization does not occur, the oocyte is degenerated and Menzies eliminates it, and the corpus luteum will actually degenerate into what is called the corpus albicans. So this is the sixth step if fertilization does not occur. The corpus luteum degenerates, and after 12 days after ovulation, progesterone and estrogen levels will drop, and the remaining follicular tissue becomes a knot of scar tissue called the corpus albicans. This signals the start of the next ovarian cycle. However, if fertilization does occur, the corpus luteum will continue producing the progesterone and a lot of the hormones until the placenta has grown around the zygote and can take over the production of the hormones. Once the placenta is actually finished growing and begins its hormone production, then the corpus luteum will degenerate away. Here we can see a picture image of the formation of the corpus luteum, that large yellow structure. If fertilization does not occur, it would shrink and degenerate over time. Now we can discuss fertilization. If fertilized by the sperm, the secondary oocyte begins meiosis II. Now, it's suspended in metaphase 2 at ovulation, and if fertilization does not occur, the meiosis II does not complete. But if it does occur, then the secondary oocyte divides into a second polar body and then into a mature ovum. Here we can actually see the finished layout of the overall process of the ovarian cycle. We can see where we've gone from the primordial follicle that would create the primary diploid oocytes and then divide them in meiosis I, where it would be suspended until it actually becomes released later on during the actual ovarian cycle start during puberty. From there, meiosis II can initiate and then finish once the actual sperm cell impregnates the oocyte. Now that we've finished with some of the functional anatomy and the overall process of the ovarian cycle, we can finish up with some of the structures in greater depth. First, we'll look at the uterine tubes now that we finish with the ovaries. The uterine tubes are otherwise known as the fallopian tubes. They are hollow, muscular structures that are roughly 13 centimeters long, and they are lined with a ciliated epithelium. This is designed to guide the oocyte towards the uterus. The distal portion will connect to the uterus, and the infundibulum is going to connect and have different projections called fimbriae. These are going to drape over the surface of the ovary, but no physical connection is made. The inner surface of the fimbriae and the infundibulum is going to be lined with cilia that are going to beat its way towards the lumen of the uterine tube. The uterine tube also has the ampulla, and ampulla, if you remember before, is simply going to be the name of the middle structure that'll be slightly enlarged. And then we have the isthmus, which is a short segment that is connected to the uterine wall. Here we can actually see the infundibulum and the fimbriae to the ampulla, which will be a slightly enlarged portion that then shrinks down to the isthmus that will work its way to the uterine cavity. The uterus is a hollow muscular organ. It's capable of great changes in size and shape. It's the size of a pear, roughly, and can expand to the size of a watermelon, or several watermelon in the case of a multiple birth. It provides mechanical protection, nutritional support, and waste removal for the embryo at weeks 1 through 8, and then the fetus when it's greater than 8 weeks. Contractions in the muscular wall are important in delivering the fetus at birth. Looking at the internal structures of the uterus is composed of 3 layers. The outer layer, known as the perimetrium, the middle muscular layer, called the myometrium, and the inner layer, called the endometrium, which consists of the inner lining that is divided into the functional zone and the basilar zone. Blood flow to the uterus is very unique in that it actually has some conditional blood vessels in it. So first, we'll go through some of the major ones. The uterine artery is going to connect to the arcuate artery, the radial artery, and then into the straight arteries. From the straight arteries, we actually have spiral arteries that will grow or decay depending upon the time of the month. So the arcuate arteries are going to encircle the endometrium. The radial arteries supply the endometrium with blood. The straight arteries are going to supply the basilar zone with blood. And then it's going to expand out to the spiral arteries that make up the functional zone. Here we can actually see an example of how the arteries are going to be laid out. Again, that uterine artery is going to come in to the arcuate artery, to the radial artery that would run its way around, and then into the straight artery that's going to make up the bottom layer. As it extends into the actual functional zone, we get the spiral arteries. Finishing with some of the other gross anatomy of the uterus, we have the uterine cavity or lumen, which is a large and superior cavity that is continuous with the isthmus of the uterine tube. We have the internal os, which is an opening or mouth to the cervical canal. The cervical canal is a constricted passageway at the inferior end of the uterus, and it leads its way to the external os, which is a curving vaginal opening into the uterus. Here we can see a diagram of some of these, namely the regions of the uterus. The body is going to make up the largest portion of it. We have the cervix, which would be the base or entrance to it, and the large bulbous top, which would be called the fundus. Some of the other structures that we can see here are, again, the uterine cavity that would lead its way down to the internal os, to the cervix and cervical canal, and then to the external os. Now that we finish with the uterus and some of the blood vessels, we can talk about the uterine cycle or menstrual cycle. This is not to be confused with the ovarian cycle, although they do link up. The uterine cycle itself is going to involve specific changes to the actual structure of the uterus that are designed to facilitate the growth and development of a fetus. Now, these are going to be monthly changes. The average length of an overall uterine or menstrual cycle is going to be about 28 days, but there is a range of between 21 to 35. The very first cycle typically begins at about 11 to 12 years old. This is called menarche. And from here, we move until menopause. Menopause can vary significantly, and when it actually occurs, it occurs as early as 45 and as late as 55. In some cases, it can occur earlier or later, depending upon the individual. Now, the regular cycle may be interrupted by illness, stress, starvation, or pregnancy. In some cases, we see the uterine cycle interrupted due to extremely low body fat in high-level athletes as well. So this is showing you a diagram of how the actual ovarian cycle lines up with the uterine cycle. Take note of the ovarian cycle and the different events that occur. Primary follicle, secondary, so on and so forth. Vesicular follicle is also known as tertiary. Same thing, so that way we don't confuse ourselves. One of the key components here is ovulation, which occurs at day 14 in the ovarian cycle. Now let's take a look at the uterine cycle. The uterine cycle occurs in 3 different phases that we'll go into: the menstrual phase, the proliferative phase, and the secretory phase. The proliferative phase transitions to the secretory phase after ovulation occurs. So the first phase of the uterine cycle is menses. This is signaled by the degeneration of the functional zone of the endometrium. Here, the spiral arteries will constrict, weaken, rupture, and die. This degeneration of the spiral arteries in the functional zone is what causes blood to actually leave the uterus during menstruation. This is endometrial sloughing phase and typically lasts between 1 to 7 days and can cause roughly 35 to 50 milliliters of blood that is lost. Following the menstrual phase, or menses, we enter into the proliferative phase. Under the influence of circulating estrogens from both the secondary and tertiary follicle that have been forming, the basilar layer begins to divide and new cells spread across the surface, eventually restoring the actual functional layer with spiral arteries that begin to grow up from the basilar layer. Then we have ovulation that occurs. Upon ovulation and the formation of the corpus luteum, the combinations of estrogens and progesterones cause us to enter into the secretory phase, where a massive enlargement of uterine glands and an increase in the thickness of the endometrium due to glandular activity occurs. This continues for about 12 days when, in the absence of fertilization, the functional layer begins to degenerate. Here we can see a final lineup of how all of the different events that occur coincide with each other. First, take note of the top diagram. This is looking at gonadotropic hormone levels, so luteinizing hormone and follicle stimulating hormone, both of which are released from the pituitary gland. These are going to equally correspond to the development of the follicular stages of the ovarian cycle, as well as the ovarian hormone levels and the endometrial lining. One of the major things that happens is ovulation. Note that ovulation is signaled by a spike in luteinizing hormone and follicle stimulating hormone. Ovulation is also going to be followed by an increase in estrogen, and then the corpus luteum is going to maintain progesterone levels as the uterine lining is going to continue development during the secretory phase. We can now move on to some of the rest of the structures of the female reproductive system, first with the vagina, which is an elastic muscular tube that extends from the cervix to the vestibule. It's going to have a highly variable diameter because it is very distensible in itself. It functions as a passageway for menstrual fluids. It receives the penis during sexual intercourse and forms a portion of the birth canal during birth. There is also a structure called the hymen. The hymen is an elastic epithelial fold that usually partially blocks the entrance to the vagina. And this is frequently absent, usually from torn during intercourse, tampon use, or heavy physical exertion. It serves an unknown function so far as we are concerned. Here we can actually see the cervix with the external os as it leads down to the vaginal canal. And then the hymen would be an epithelial fold that would be the entrance to the vagina. Then we can see it's going to exit via the vestibule and have the labia minora. Here we can actually see some of the external genitalia where we have the labia minora and then the labia majora. Minora is going to be more internal to the majora. Just above the actual vaginal entrance, we have the urethra, and then the clitoris just above that. The final structures to talk about are the mammary glands. The mammary glands provide nourishment or milk for the developing infant. The milk production is called lactation and is controlled by hormones like prolactin and oxytocin released by the reproductive system and the placenta. They are located on the anterior chest directly over the pectoralis major muscle. The structure of the mammary gland it's actually a lobule and has a secretory alveoli. So these are going to be modified sebaceous sweat glands that have been modified into milk-producing lobes. Now the ducts from the lobules converge into one lactiferous duct per lobe, and it expands near the nipple into the lactiferous sinus. The nipple is going to be the projection where 15 to 20 lactiferous sinuses open onto that surface. And then we have the areola, which is simply the reddish brown skin around the nipple. The grainy texture is from the sebaceous gland deep to the surface. Here we can actually see the fat pads and then the lactiferous ducts that make up the breast tissue. Now, one concern that we need to have with mammary glands and is going to be breast cancer. Breast cancer is malignant metastasizing tumors of the mammary glands. It is the leading cause of death in women ages 35 to 45 and is most common in women over the age of 50. Notable risk factors include a family history of breast cancer, a first pregnancy after the age of 30, and then early menarche or late menopause. Treatments for this include, of course, surgery, radiation, chemotherapy, and hormones, but the best treatment overall is going to be early diagnosis. Surgical removal may involve removal of part or all of the mammary gland as well as the axillary lymph nodes. Here we can actually see an example of a mammogram looking specifically at the breast cancer where it's a calcification of that lactiferous duct. The final thing to leave you with is talking about fertilization and the placenta, and fertilization and pregnancy. Now, if fertilized by sperm, the now complete zygote will then bury itself in the wall of the uterus. This process is called, of course, implantation. Implantation induces the formation of the placenta, which will produce human chorionic gonadotropin, or HCG. Now, this hormone is a signal for pregnancy. HCG itself causes the corpus luteum to continue functioning for several months. The implantation also induces enlargement of the mammary glands, and at the end of the 6th month of pregnancy, the production and storage of milk in the lactiferous sinus.